Dr. Kormos, as you know, we've initiated a process in the ISHLT that focuses on recording the ongoing history of the Society as it parallels the history of heart and lung transplantation as well as mechanical circulatory support. To that end, we're interviewing those, such as yourself, who have played a prominent role in this history. So, you grew up in Ontario. And your graduate and postgraduate education took place there in the late 1970s and early 80s. And you majored in psychology in undergraduate school and then went into medicine. What led to your interest in medicine, surgery, and then ultimately cardiac surgery?
Well, my interests out of psychology quickly led me to a specific interest in sensory psychology, which very quickly led to an interest in neuropsychology and eventually neurosurgery. And I realized that all the great advances were happening in surgery and medicine, and that although the psychology background was wonderful, I really felt that the world of human care was going to be where I wanted to go. So I entered medical school in the University of Western Ontario in London, Ontario in Canada, and very quickly migrated into a lot of rotations that included neurosurgical rotations. And when I finished medical school and went to Toronto in 1976, I was paired with a neurosurgeon who, for a lack of a resident who had mononucleosis, quickly mentored me, and I was very quickly drafted into the neurosurgical program the following year. I spent 3 years in neurosurgery, and unfortunately my interests in motor racing conflicted with the feelings of the neurosurgeons, and I was again embraced by the cardiac surgeons, and at the time cardiac surgery was exploding. A lot of new ventures were occurring, and so I switched to the cardiac surgical program at that time.
During your fellowship in cardiac surgery, you were a lead developer in a protocol for short-term ventricular assist devices. How did this come about?
So, through a small project that I had done, I began reading the literature on mechanical circulatory support, and I'd always been somebody that was interested in tinkering with things. I think I could have probably been a good engineer at one point in my career had it shifted that way. But in any event, a surgeon there, Dr. Hugh Scully, who was one of the fine cardiac surgeons in Toronto, encouraged me to write a protocol. And so we, in fact, did the first LVAD, I think, in Ontario, if not Canada, back then it was 1984. With that protocol. Interestingly enough, Leonard Golding at the Cleveland Clinic was instrumental in helping me to develop that career, because I can't think of a better mentor at the time. Here's a fellow wanting to do an LVAD, and at that time we used a biomedicus pump because there wasn't anything else. And he mentored me through that project on the phone. I literally called him one night, and Leonard talked me through it. And it was a successful LVAD with a successful wean. And that morning after, which I sat at the bedside for about 24 hours, and I came out, sat in the parking lot, and I said, this is it. This is what I want to do.
Had anyone at your institution used an LVAD prior to that time?
No.
So you weren't really intending to get involved in mechanical circulatory support when you arrived at Toronto then?
No, not at all.
And you were just captured by the magic of not only the engineering aspect of it, but the medical aspect of it as well, sounds like.
Absolutely, and then we did a couple other patients, and we had another patient that survived for about 2.5 weeks, extubated, getting better on another biomedicus LVAD at the time, but she wasn't weanable. And that led me to search the literature to see who were doing heart transplants the most, and it led me to give Bartley Griffith a call at the University of Pittsburgh, asking him, so here's a young guy calling Pittsburgh, would you be willing to take this patient from Canada and do a heart transplant? Of course, interestingly enough, Bart said, there's no way we would ever do that, it's too high risk. That following summer, I ran into Bart and Bob Hardesty, And they were doing 90 transplants a year at that point and getting very burned out very quickly. And at an STS meeting in San Antonio, we developed a very quick discussion and a quick realization that we were both interested in the same thing. They were interested in developing a device program. I was interested in doing that. And I had actually committed to go to Hershey. But the spot opened up in January of that year in '85, and they said, come, you can go to Hershey in July. And I came, and they quickly talked me out of going to Hershey. And so from that point on, I stayed.
Your interest in mechanical circulatory support and heart transplantation are related. You know, it's interesting that your interest in this really formed at the end of what many would call the end of the dark period of transplantation, right after cyclosporin was introduced. And so it was actually becoming possible again around that time. And so you were really interested, so in Toronto, you were doing heart failure using LVADs, but it sounds like you were also looking for a way to extend beyond that and do heart transplantation in addition to that. And you couldn't do that in Toronto, could you?
No, there was no heart transplant program at the time.
Well, what was transplantation? What was it like in Pittsburgh at that time? What sort of challenges did you guys have? You said that it was a very high volume center, and that alone is one challenge.
Well, of course, this was a time when the preoperative assessment of a donor didn't exist. From the technical perspective, it all rested in the eyes of the surgeon that went out and evaluated the material. And so that first year I was there, in '85, I spent time in the lab. And in that lab, we did a lot of research on organ preservation and studying the effects of brain death on organs. And I also went on a lot of donor runs with Bob Hardesty, who was probably one of the premier surgeons in understanding how to assess and recover organs. So I did a lot of that in that first year. And then in the next year, I became the first transplant fellow they ever had. Of course, when I arrived, Dr. Henry Bonson was very kind to accept me in the program, but also informed me there was no pay. So we actually took some risk, spending some of our own money, and I was also funded through some efforts in Toronto. But we made it through, and that next year was unbelievable because I was either transplanting or out on a donor run almost every night, and we were one of the few centers doing high volume transplant at the time. So we were all over. I mean, we were flying to Texas and southern U.S., Canada, everywhere. And at that time, one of the most dramatic parts of the learning experience was that Tom Starzl was often out on the plane with you. And watching him manage the team was an experience that was absolutely captivating.
It must have been very useful as well, since he had been doing transplantation for so long by that time. And organ procurement was so much in its infancy at the time.
That's right.
What were some of the things that you learned watching those other guys at the same time?
Well, you know, it's interesting because at that time, we did everything. I mean, we managed, you know, there were no professional OPOs. And the success of organ procurement, Hardesty and Starzl recognized very early that a large part of it was the ability to communicate and engender a partnership with the team whose hospital was inviting you to come in and get those organs. And there was a lot of pride at that time in those centers giving up those organs because it was a relatively new thing to do. It was emotional, it was exciting. We learned a tremendous amount at that time, unfortunately, firsthand about the limits of organs, because at that time there was really no information. So we learned very quickly about organ size mismatch, about the inadvisability of undersizing patients with pulmonary hypertension.
Some painful lessons, I
Yeah,
imagine.
I mean, they were harsh.
Now, in that same year, the first successful total artificial heart bridge transplant took place as well. How did that influence you? Were you aware of it at the time?
Oh yeah, well, there was a little competition there, to be honest, because Bart Griffith was beaten by Jack Copeland literally by about a week. Both centers had gotten into that protocol, and we had pretty much completed our training. But Jack did the first bridge, and I think Bart followed him literally a couple weeks later. And again, you know, it was one of those things where we sat at the bedside. Myself, an engineer, we camped out, and I can't, you know, the amount of information processing that took place at that time was enormous. And learning the experience taught us an awful lot, again, about what you can do with acutely ill and dying patients. I mean, many of those patients were being resuscitated to the operating room, essentially, to get their total hearts. And we realized that was not the way to do business very quickly.
Yeah, what were some of those issues that you ran into at the time? You're sitting there by the patient's bedside, processing the information, thinking about what can we do better, what's wrong with this picture, what are some of the engineering problems that and clinical problems that you ran into with some of these patients?
Well, you know, I think some of it, there are two aspects. Some of it had to do with the engineering and the equipment, and it was very primitive. You know, we had one of these big portable compact computers sitting on top of the console that we actually were able to dial into by modem from home. And we'd get a call from the nurse, and you dial in and look at the waveforms, and nobody really knew what they were looking at. I mean, we were trying to develop algorithms to understand what cardiac tamponade looked like with a total heart, because contrary to belief, it could happen. And so we spent a lot of time understanding that. We spent an awful lot of time understanding the physiology of operating on critically ill patients with cardiogenic shock, the massive amount of vasodilatation that took place, and the high inflammatory rate. And this, again, was a connection with Starzl, because he dealt with this all the time with the failing liver. And when we saw patients like this that came out of the operating room with wide open peripheral resistance, it was really he that pointed out to us, well, look, I see this all the time with the liver transplants. You've got a patient with a dead liver. You shouldn't be putting a VAD in those patients. So we learned, again, an awful lot about that.
In the 1990s, you began publishing your experience with the NovaCore device and the Jarvik Total Artificial Heart. Can you tell us about that experience as well, and the challenges that you faced at that time as well? That was a completely new generation of devices versus the one that you just described. It must have been quite different.
We did a lot of interesting things then. At that point, I began, under Bart's challenge, to examine the effects of LVADs on the right ventricle. I would say that first NovaCore experience was probably the only LVAD-only determined trial ever carried out, whereby you just did the LVAD and then you took your hits on the right ventricle. And so it gave us an opportunity to really study hard what affected the right ventricle, because we didn't have a bailout for anything else. We didn't have Thoratec at that time. And we did some fascinating experiences. I mean, experiments. We did some fascinating experiments at that time. We placed sonomicrometry crystals in the hearts to really study, you know, the motion of the ventricles on the right and left side. You could never do that now, but we learned such an amount about what how the right ventricle reacted to the left ventricular assist device. And the conclusion of all that was that, again, it boiled down to how sick the patient was. The sicker the patient, the less likely you were going to get away with an LVAD alone, because of all the issues of bleeding and damaging the lungs and everything else. So we pretty much determined that the right ventricle was pretty robust in most cases with an LVAD alone, but you could sure mess it up easily.
Now, what about the Jarvik heart? How was that?
Well, you know, there's a classic slide that Bart showed at that time at one of the, I think he showed it at the American, Bart showed this classic slide at the STS, Society of Thoracic Surgeons, where he had the mediastinum and he had the total heart, and under it was sitting a Petri dish. And that pretty much summarized our early experience. Because of the class of patient we did, We saw a tremendous amount of infection in mediastinitis around the VAD or around the total heart, and most of it were bacteria that came from the lung or from lines that pre-existed the implant. So again, we felt that we need to leave the native heart in the chest. This is how we came to that conclusion, that we have to move to the LVAD. Not so much because of our understanding that an LVAD alone would be good, but we just felt that taking out all the tissue out of the mediastinum left the mediastinum in a very high-risk situation for infection. So we did about 20 of those and pretty much abandoned it, and then moved to the NovaCore.
At that time, were you completely devoted to the LVAD and artificial heart? What were some of the other activities that you did around that period?
So in that early era, we also were trying to understand the best way to get patients out of the hospital, because we very quickly recognized that if this technology was going to be successful, we can't keep patients in hospital, because up to that point, that was the way it was. You waited, you got your heart transplant, and then you went home.
So you were very interested in device size and controller technology, and
in particular,
things of that sort.
The outpatient, facilitating outpatient care.
Yes. And in fact, it was around this time I noticed that you became involved in many of the bioengineering aspects of mechanical circulatory support during this period. How did that come about, and how did you facilitate that at your institution? Because you were involved in setting up some teaching.
When that program started, Bart Griffith and an associate, Harvey Borowitz, had a very close research and clinical relationship. Harvey is now the chair of bioengineering at Pitt, but at that time he was a professor of bioengineering. And the two of them quickly realized that there was a natural synergy between bioengineers and what we were doing. Because Bart had always encouraged me to think of this field in a way that would lead to new developments in the technology. And to do that, you had to work with the bioengineers. You know, they were the ones that understood flow and rheology and all the things that happen to the human being in the blood when it came in contact with a device. So we had formed a very close relationship with Dr. Borowitz and all his biomedical engineers. And in fact, at that time, bioengineers worked with us very closely to help monitor the devices. So it was natural that in spending a lot of time, in fact, at that time, my office was down in the research floor, and next to me was Harvey and Jim Antaki, who's now inventing pediatric devices. And we all worked very closely, throwing around ideas about how to improve devices and how to develop new technologies and study the ones we were using. So we incorporated these bioengineers into our program. We rounded with them. We looked at the complications and tried to understand. So Harvey got me interested in all the bioengineering effects and the rheology of the blood as to how it changed when it was exposed to a device. So it was just, you know, to me, Pittsburgh was so different than anything I had seen in Canada. The opportunity that presented itself with that collaboration of scientists and clinicians being able to work together was just something I'd never been exposed to.
Was there a particular aspect of bioengineering that interested you regarding the device? Any particular problems that you found captivating or fascinating, such as the surfaces or fluid flow or anything of that nature?
Initially, it was the fluid dynamics and the blood rheology. We then moved to try and understand how to better develop controllers, so that the controllers would be more sensitive to the patient, and to also understand the information, the subtle information that came from the controllers and the waveforms, to understand what was actually happening with the pump and the patient together. And in fact, we had developed some pretty sophisticated algorithms looking at the waveforms, again, to know, for example, when the heart began to improve its function, when it began to recover. The engineers provided us with all sorts of interesting data in that fashion.
Now, these were primarily pulsatile devices at that time.
They were all pulsatile pumps.
So when did you start getting involved in axial flow devices? And how did that come about? That is a particularly fascinating story.
Well, again, there was an RFP that came out in the 90s, around 94, I think, 95, from the NHLBI to develop new devices. And a number of those contracts were for rotary blood pumps. Some of those pumps have disappeared, but one of those was a group, again, that formed through Harvey's connection with the Nimbus Corporation. He knew, when Nimbus had developed a small rotary device out in California. And so we worked with them, got the RFP, and began work in the lab on finalizing designs for a rotary blood pump, for an axial blood pump. And at that time, things got really, really interesting because we hired a gentleman, for example, whose life had been spent designing the turbines and jet engines for Pratt & Whitney and GE. And he sat at the computer, and we learned so much about how subtle changes in the angle of flow or angle of attack of these blades would change the blood flow and reduce the hemolysis. Watching them come up with iterations was just phenomenal. Again, Jim Antaki and Harvey Boritz were very instrumental in helping us to understand that. And then we did all kinds of fascinating pulse duplicator experiments, demonstrating, in fact, that those designs did what we hoped to do. So that device went through a number of iterations, and eventually that device has become the HeartMate 2. Another company eventually purchased this, and that then was subsequently purchased by Thoratec. But we had actually had a very nice design of that device with low hemolysis rates, no thromboembolism in the animals. And when Thoratec purchased it, they had suggested that we make some modifications to ease it through the FDA, and one of those was to coat the internal surfaces with a sintered titanium. And they got very aggressive with that sintered titanium coating. And about that time, we began to see problems. And it was at that time that we suggested they should go back to the old version because it was perfect. It was at that time that Bud Fraser then got involved with their research and actually took over some of that work and got the new version of the device. And so to this day, you'll hear Bud say that they helped develop the HeartMate 2, bringing it up from the failed version at the University of Pittsburgh. But we, in fact, had a good version to begin with. So it was during that era that I think we got very excited in actual device development. And we're very satisfied to see that eventually came to human use.
Yeah, there were several really innovative aspects of that device. The magnetic bearings, the coatings, the blades, everything that was done from an engineering perspective was really quite fascinating. And can you give us a sense about the period of time that took place? Not in terms of when, but also how long it took before you arrived at a design that you felt was reasonably useful in human beings.
The different iterations that we went through till we got a good pump probably took 4 years, almost a good 4 to 5 years. It wasn't really until Nimbus was sold to the larger company, and we then began finalizing the version for the FDA that we really had the full design. But it took a good 5 years of work to get it to the point where we felt we had a device that would be compatible for human use.
And was it very difficult to get it approved by the FDA?
Well, to get it to I was astounded by the amount of work and documentation and regulatory work that had to be done at that time. None of us really appreciated that. We were all just doing our science. But that was a huge eye-opener just to understand that they measured the paperwork in, I believe, yards. And so it took a tremendous amount of work.
Now, I wanted to backtrack a little bit. You were the 15th ISHLT president in 1999 to 2000. What were some of the challenges that you faced at that time leading the society?
Well, it was an interesting time. I think I, of course, had a prejudice at that time. I wanted to see mechanical support incorporated even more than it had been. And we were slowly beginning to get some acceptance. We developed a Mechanical Circulatory Support Council around that time. And one of the big challenges at that time was to develop a registry that paralleled the heart and lung registry. And there was none for devices. And we had just, guys like Pierre Portner and Don Hill and Vic Poirier, all the folks that were in the device world at that time. We debated for hours on what a registry should be, how it should be developed, and then we'd have Bud Fraser on the other side saying that these registries probably didn't mean much. But we really wanted to get this done, and we met for hours on end and deliberated on what the definition should be, the inclusion criteria, how you would define adverse events. And it really, at that time, I think set the stage for what now has become Intermax. But at that time, we just wanted to collect data similar to what was being collected in heart and lung. So that was one of the things that was one of the challenges that we were trying to develop. We also, at that time, began to recognize how important supporting the younger members of the society were, and we've worked very hard to get the support to get grants for young investigators and scientists, and we were very successful in doing that, and that was something that was important. We also faced at that time a change in the leadership of the journal. It was at that time that Jim Kirkland was taking over from Maria Rosa Costanzo, and there were a lot of debates about the journal's viability, whether the economics would support the ongoing activity of the journal, who could get it, we also changed publishers at that time. So there were a lot of interesting discussions about that. We also, at that time, realized that we'd never been to Asia for our meeting. And it ended up on my shoulders that Japan would be the first time we'd venture out of Europe or North America. And Japan was an economic challenge. It was a cultural challenge, but it was well worth it. I mean, the meeting turned out to be an excellent meeting. Those that went culturally enjoyed it. So we had a lot of fun. It was good for us, I think, at the time. We felt we needed to support Japan because at that time they were trying to develop their transplant programs. So to get that through the board and through the society took a fair amount of creativity, but it was worth it.
Now, do you have any specific advice for young surgeons that are contemplating a career in cardiac surgery or transplantation?
I think that, cardiac surgery is a career that I would never have changed. I think that for those that enter it, it requires a fair amount of dynamic interaction, thinking on your feet, understanding physiology, understanding spatial concepts. It's a field that is very rewarding. I think cardiac surgery is going through tremendous changes at this time and a lot of challenges. But I do believe that we still offer young candidates a tremendous career as technology and cardiology begin to get closer and closer. I think many of the things that we've done as we see evolve from cardiac surgery end up in the hands of cardiologists, which is a natural progression. But having said that, that challenge to develop these new technologies, these new procedures is still there. Transplantation and mechanical support, I think, is only going to get more and more interesting. And it offers a surgeon that unique combination of medicine and surgery that I don't think exists in many other surgical specialties. A lot of surgical specialties vary in their degree of separation from the technical and the medical aspects, but I think transplantation has a tendency to bring those two together more than anything else, and that was one of the things I learned early on in training in Pittsburgh, but I think it still exists. Although cardiologists and a lot of specialists now have taken the responsibility of long-term care off the hands of the surgeons, I don't think you can be a good transplant surgeon if you don't understand all those medical aspects and the interrelationships that occur with immune suppression and infectious diseases and all that. So I think it offers a really unique opportunity for a surgeon to be more than just a technician.
And there's the other unique element in terms of mechanical circulatory support is also your interaction not only with a cardiologist but with engineers.
Exactly.
As well, particularly in the developmental aspect of it. Where do you see these devices going from this point? Right now, the HeartMate 2 appears to be, doing very well. Where do you think the field is going?
So, is it mature? No. I'm very happy that the technology is is maturing to a level where it's easier to use. The results are much better. People are recognizing that we can move the indications. But to be perfectly honest, this is very primitive technology. If you want to look at artificial organs from the perspective of regenerative medicine, which is something we look at more and more all the time, then the heart is not just a pump. There are a tremendous amount of control functions, the interaction and the ability to respond to the demands of exercise, emotion, all those things. And by emotion, I'm talking fear and panic. Those things, we're nowhere near that. I think our ability to truly understand the relationships between the surfaces is very primitive. I'm frustrated that we're still talking about driveline infections. These have to go away. I don't consider a left ventricular assist device a device. It really needs to be a system. And I appreciate that our technology is so good that the pump doesn't fail. But the reliability of a pump can't be separated from its environment. And if a pump is reliable engineering-wise, that's great, but it needs to be reliable in vivo, and that still provides us with some challenges. I think that in the future, this technology will get to a point where the power supply will no longer be a limit as it is now, because battery technology will improve. I believe that integrated sensors will feed back information from these devices to help control them, so that we're not doing echoes on patients to understand where we're running the pump. This will all be information that will be obtained in vivo. And I believe drive lines will disappear. So we got a ways to go. It's going to keep us busy for another 10, 15 years.
It's an exciting area, and you were certainly one of the pioneers in this area as well. And is there anything further that I've missed as far as things that we should talk about?
I think one of the things that really allows us to move forward in a way that's intelligent in this field is the fact that we have such a viable society like ISHLT. It is a living organism. It changes as the needs of the field change, which is really nice. And it does that, I think, because inherently it's been a society that engages the leadership when they're youthful, which I think is key to the fact that it can change as quickly as it does and adapt to the needs of its members. I think that it's a society that has provided an unbelievable platform for revolutionizing how we do things, and it will continue to do that. And I think the more that the young people around recognize that they can play a huge role in this society and that it's looking for them, I think the more we'll grow.
Well, thank you very much.
You're welcome. Pleasure.